I'm really excited that the recording is in progress, and we have three great speakers today. So the first is Micaela Consens, and she is in her second year of her PhD in computer science at the University of Toronto, and she's focusing on machine learning applications for healthcare. And so I guess the premise from what I understand is that her efforts are to reveal kind of how human molecular machinery works. And I'm very excited to hear her project on transforming genomic interpretability on the DNABERT case study. So with that, I'll let you take it away.
Awesome. All right. Well, yeah, so my name's Mika, and I'll just be presenting some work that I've done recently. So to begin, a little bit of background. What are transformers? Maybe a lot of you have recently heard about transformers, given that ChatGPT has been so popular. ChatGPT is a specific transformer that generates, that's why it's chat generative pre-trained transformer, and it generates text. But essentially the transformer is just a deep learning model architecture that uses an attention mechanism to dynamically assign relevance or weights to pairwise relations between inputs. So here we have kind of like the basic structure of the transformer. This is the encoder only aspect of the transformer, which is what we'll be focusing on. And so if you think about ChatGPT, it takes in some kind of text input and it ends up outputting some response to you. But we're actually only going to be looking at the part of the transformer that encodes whatever input it's given and makes a representation from that. So this is a subset of the transformer architecture that is encoder only, and it takes in inputs. And again, what makes that transformer architecture so special is this attention mechanism, which is essentially composed of queries, keys, and values, which are just transformations of whatever is inputted into the transformer. And this calculation here allows for pairwise relevancies to be calculated between all aspects of the input. And then they're routed through all the inputs so that every input has access to the relevance scores of every pairwise relation of inputs. So in the context of DNA sequence, which since we'll be focusing on transformers applied to DNA sequence, you can think of the input as being a DNA sequence. And then this attention mechanism allows us to get the relevance of every nucleotide relative to every other nucleotide. So you can imagine in the sequence at this guanine, it's able to have a relevancy score calculated for every other nucleotide in the sequence. And that is what this attention mechanism allows, is it kind of decides how relevant every other base pair is for a specific base pair. That's kind of what makes transformers special. The specific transformer model that we'll be focusing on is called DNABERT. So DNABERT is a transformer model that was trained on the entire human genome. So instead of being fed in text prompts to be able to chat with you, the DNABERT model was actually just given the entire human genome sequence as input. And the way it was trained was actually using this test that's called mask language modeling, which is very common in natural language processing, where you mask out or kind of hide specific regions of, in this case, the human genome, and you send it into the model with specific masks. And what the model does is it tries to predict the mask regions. So it uses all of the information around those regions to help it predict what might be in those regions in order to reconstruct the original sequence. And through this process, the DNABERT model learns the kind of grammar of the human genome. And the way that this model is actually trained is, instead of just feeding it the entire human genome, is it actually gets a K-merized version of the human genome. And the K-mer is 6. So like it gets sent in instead of the actual entire sequence that makes up the human genome. There's a sliding window of size 6 that creates these K-mers. So from a single sequence, you would create multiple different 6 nucleotide sized K-mers that gets fed into the model. And this is the way that the model is trained. So you're actually able to use this model that's been trained entirely on the human genome and fine tune it for another specific task. So instead of the model only being able to predict certain tokens that are masked out, you can actually take extra data that's for a specific task. Like let's say you had a series of sequences and you wanted to be able to determine whether that sequence was an enhancer region. You could use that data that has sequences that are labeled as enhancer regions and sequences that aren't, and you could fine tune the model such that it's able to make a specific prediction on the kind of sequence that the model is given. So the pre-trained model exists trained on the entire human genome, and then you're able to fine tune it for a bunch of different tasks. And again, the data that we actually send into the model has to be this K-merized version of the DNA sequence. All right, so the last kind of piece of terminology that we need to get through is layer-wise relevance propagation, or as I'll be talking about it, LRP. And this is essentially a method that's used to understand and interpret decisions made by deep learning models. And the way that this works is it kind of attributes contributions of each input feature to the final decision of a model. So imagine if we had a neural network that was trained to predict, given a set of images, whether that image had a dog or a cat in it. Let's say we feed the model an image that has both a dog and a cat, and the network decides that the image is of a dog. So we want to kind of understand why the model made that prediction, because it's not obvious. So we would start with taking a look at the input features that are fed into the model, right? In the usual kind of setup for training or for testing, for any kind of prediction, we take a set of input features, we feed them into the model, they pass through the first layer into the hidden states, and then eventually they reach the final classification decision. In LRP, we actually start backwards. We start from this classification decision, this decision that that the image contains a dog, and we propagate the decision backwards through the layers so that we understand how much each neuron contributes to the final classification decision, starting from the decision until we move all the way back to the input features, and we can determine which were the input features that actually contributed most to the decision that the model made. And you can think about this in the context of the DNABERT model for genomic sequences as, let's say we send in a specific DNA sequence. It just so happens that DNABERT makes the prediction that the sequence is actually of a human enhancer sequence. We can then take the specific decision, use LRP to move backwards through the model and find out which were the regions of that DNA sequence that actually contributed to the decision. Like, what are the common motifs that make up this human enhancer region? So mathematically, this kind of means that if we want to figure out the specific relevance of a certain neuron in a model, it would be determined by the sum of its influence on all of the neurons K in the following layer that are connected to it, times each of these neurons' specific relevance. And because we have this rule for LRP, which is this conservation rule, meaning that the relevance at every layer is equal, we have to actually do this division over the sum of the contribution of all neurons in a layer. And we determine the contribution of these neurons by kind of taking a look at what the activation of a specific neuron is and the weight of the connection between these specific neurons. So this neuron's relevance, this neuron J, its relevance is determined by the strength of its connection to these previous neurons, as well as its activation, the relevance of these neurons that was actually given from its classification position. All right, so now the experiments that we actually did. So we started with this pre-trained DNABERT model, pre-trained on the entire human genome sequence, and we fine-tuned it on 2 specific tasks. So one of the tasks was to be able to predict human enhancers. So given a sequence, can you predict whether it's a human enhancer region or a non-human enhancer region? And the second task was to predict TATA promoters. So given a specific region, is that region a TATA promoter or not? Now, the next step was to take each of these models and calculate the layer-wise relevance propagation, or LRP scores. We also calculated a few other interpretability scores, and we extracted the raw attention scores themselves from 500 samples from each of the classes, so just from a subset of the data. Then we found the top regions identified by each score and mutagenized them to see how this would affect model accuracy. So the idea being that if we found a very, very important region of the DNA sequence that was really important for the model making that classification decision that region is an enhancer, and we mutagenize that region, we would expect that the model would actually not be able to determine that that sequence was an enhancer anymore. So the model accuracy would drop. So that means that the score that actually identifies the most important regions would result in the mutagenesis experiment giving the biggest drop in accuracy. So the score that best explains model decisions causes the biggest drop in model accuracy. So to begin, the first step that we did, again, was this fine-tuning of the DNABERT models. The enhancer model actually had an 86% accuracy after training, and the Tata promoter model had a 92% accuracy for the task. So both of these models were able to perform the task that they were fine-tuned to quite well. The next step was to actually score the k-mers per model. So like I mentioned earlier, the DNABERT model doesn't actually take in DNA sequences. It takes in k-merized version of DNA sequence. So when we get the important regions identified by any of these scores, we're actually going to get the k-mers that were identified. So what you can see here is specifically for the Tata class. So these are regions that are Tata positive. They're a subset of the data set for which all of these regions actually do have Tata regions. You can see on the x-axis, we have the kind of length of the sequence, and this is actually the length of the k-mers. And on the y-axis, we have the number of examples. There's about 500 examples for the class, and you can see the LRP highlighted most important regions and the attention highlighted most important regions. It's a bit difficult to see, but there is some concordance between the regions that are identified as most important by attention and the regions that are identified as most important by LRP. There is also some differences. So these, the raw attention scores and the LRP scores aren't necessarily capturing the same most important regions. So the next step was to mutagenize these regions. So let's say we have the k-mers that were identified as most important. We actually turn these k-merized DNA sequences back into the original sequence to determine the specific nucleotide that's of interest. And then we mutagenize that specific nucleotide, meaning we just change the base pair at that position. And we return the DNA sequence back into k-mers in order to feed it to the model, because that's the kind of input that the model expects. Note that even if you just mutagenize like one base pair, you end up affecting several k-mers. All right, so these are the results of the experiment. At a high level, the model learns the positive class. So I'll walk you through what everything in the table is. So in the table, we have several different tasks, and they're split by the models. So starting at the top, if we focus on the Tata promoter model, we have the subset of regions that are Tata negative or non-Tata, and then we have the regions that are Tata positive. And here you can see the performance of the model on just that specific class when n equals 0, which means that no nucleotides were mutated. So this is just the performance of the model in identifying the specific region. So in identifying non-Tata regions, it almost has an 88% accuracy. And in identifying Tata regions, it actually has a roughly 97% accuracy. However, when we mutate every position in the sequence, so when n equals 200, we're basically mutating every single base pair in the sequence. And that means that we have an entirely random sequence. The model accuracy drops as expected. However, for the non-Tata region, it doesn't actually drop that much. You can see on like actual sequences, the model has an 88% accuracy, but if you send it something entirely random, the model actually has a 68% accuracy, which is pretty high, meaning that if you give it a totally random sequence, it will pretty much guess that it's a non-Tata region. However, if you send the model entirely random sequences labeled as Tata, the model doesn't actually guess that those regions are Tata regions, meaning it's able to capture some kind of knowledge around what a Tata region is rather than what a non-Tata region is. And it's very similar for the enhancer model, where the model's accuracy drops a lot on random for the enhancer regions and not that much for non-enhancer. And this kind of lines up with our intuition for what you would expect a model to learn in this kind of a two classification scenario, where it's like if you're asked to learn like what a unicorn is and what a not unicorn is, you're not going to learn what everything else on Earth is but a unicorn. You're just going to learn to identify a unicorn. And then if you don't see those characteristics, you just won't assume that it's a unicorn. So essentially what we see is that given positive examples of a specific class and negative examples that do not belong to the class, but may not follow a specific pattern beyond and not being part of the class, the model will learn only the positive class. So this kind of lines up with our intuition. Now, on this section of the table, you can see we've actually only mutated 20 base pairs, n equals 20. And what that means is that we've selected the top 20 base pairs as identified by either LRP scores or attention. And we're trying to see which of these scores drops the model accuracy the most. So in this case, we can actually see that LRP slightly outperforms attention in both cases, meaning that LRP is identifying more important regions than attention scores alone. It's important to note that they're pretty close and that actually the drop in the Tata model is not that significant. And most importantly, this kind of mutagenesis of 20 positions of the sequence does not converge on random performance. Like you can see even the enhancer model, which with 20 positions mutated, drops the accuracy quite a bit. It's still not the same as entirely random, which provides some kind of preliminary suggestions that information between within genomic sequences is actually quite distributed after all. So this is another way to view this information. And here we have actually a lot of the other interpretability scores pictures than the ones I've discussed. So these are quite common. You'll see like GradCam, rollout, and then there's a few different variations of LRP scores, which are calculated from varying different positions and propagated differently throughout the model. But you can see on the x-axis, I have the number of nucleotide positions mutated. And on the y-axis, I have the model's accuracy. So this red dotted line represents the unmutated accuracy when given the enhancer class samples. And then you can see at just mutating one nucleotide, how much the accuracy drops already from the start, from this unmutated accuracy. And here, this blue band is the 95% confidence interval for just a random mutagenesis experiment. So that's if I just randomly selected n positions to mutate in the mutagenesis experiment, as opposed to selecting the top n nucleotides as identified by some score. So what you can see here is that two of the LRP scores, along with the attention score, actually are able to drop the model accuracy significantly more than random. And you can actually see that one of these LRP scores actually drops the accuracy more than attention scores alone for this enhancer model. For the Tata region, we can see a similar sort of graph, except here, obviously, the sequences that are being mutated are the Tata regions, as opposed to the enhancer ones, and the model that's being evaluated is the Tata promoter model. So again, this is the unmutated accuracy of the model on the region. And you can see here, these LRP scores are in blue. And actually, the attention score, which is in yellow, does not actually outperform random mutagenesis. Attention is not able to reliably identify positions that are more important than just selecting random positions alone. Something to note, however, is that the attention is not the accuracy of the model is not degrading significantly, even like is not degrading a huge amount either way with these mutations that we're doing. So some takeaways from this work are that the preliminary results suggest there might be a reason to explore using LRP-based scores as a better way to visualize and understand how these models learn genomic data. Further work has to be done on more diverse tasks, so on testing these models outside of just promoter or enhancer predictions, on larger data sets, on longer sequences. Again, this is about 200 base pair long sequences, and across a larger mutational burden window. So it would be nice to continue the mutagenesis experiments beyond just 20 nucleotides to see if we can approach that random performance. And the goal would just be to better understand which LRP-based scores are best suited for model interpretability, and to discover if attention scores actually aren't better than random in some cases. So this is my bibliography, and I would like to thank my supervisors, Dr. Boeing and Dr. Alan Moses, along with Dr. Nicholas Paperno.
Thank you so much. That was an awesome presentation. So we do have a few more minutes for questions from the students or anyone from the T-CAIREM group as well. But yeah, you did a phenomenal job explaining science. So Conrad, you can go first.
Thank you, Mika, for the wonderful presentation. My question relates to the K-mer size, and perhaps this was addressed kind of later on in the presentation. So I know that I've seen that, for example, the DNABERT model can be limited to, I believe, up to 500 nucleotides. I was wondering for example, what informed the selection of a 6 nucleotide size of K-mers, potentially given the context that there might be some, let's say, like promoter sequences kind of ahead of, let's say, those other regions which you're interested in, which might better inform kind of the identification of those regions.
Sorry, so what are you saying specifically about the K-mer regions?
I was wondering, again, basically what informed the selection of a 6 nucleotide size for the K-mers, and whether you feel like there are any potential limitations in that.
Yeah, totally. That's a great question. So the authors of the DNABERT paper actually tried out a bunch of different K-mer sizes. I think from like 2 to 6, and it just so happened that the 6-mer performed the best. That could be because it's like able to capture like the largest window that they tried. And a potential limitation could be that like if they'd done a K-mer size that was much larger, like 12 or something, the model actually would have performed even better because they saw this increase of increasing the K-mer size. But yeah, their justification for the 6-mer was just that it performed the best out of the ones that they tested. And I do definitely think that we are seeing this trend in genomics that these models that are able to capture longer and longer range interactions have better performance. So I definitely think increasing the size of even like beyond 512 base pairs. There's this new paper that came out, it's like hyena DNA or something, which has like this huge context, and I'm sure it will change the way we look at these kind of problems.
Amazing.
Great question.
Thank you so much.
I also have a question if no one else has raised their hand that I can see. So I think that was phenomenal. Where do you see kind of this work being applied within medicine? I know genomics is kind of like the broad science field, but are there specific like regions or diseases, or do you have kind of any ideas on next steps for translation?
Yeah, for sure. That's a great question. So, I mean, right now the goal would just be to create a very strong method to be able to use to kind of understand why these models make certain decisions given DNA sequences. The goal is, again, like to map back to these inputs and understand what are the specific nucleotides or sequences or motifs that are contributing to certain decisions. And if you think about it in the context of like personalized medicine, if we end up like having models that are able to make predictions about longevity or health or like specific disease outcomes, it would be really good to be able to map back and understand exactly what are the regions that are contributing to these decisions and whether those line up with like kind of what we found in GWAS studies or in like specific pedigree analysis.
That makes a lot of sense. Yeah. And I think your work would lend really well to that. Does anyone else have a question? If not, we can proceed to the next presenter, but we do have like 4 minutes if anyone else would like to ask a question. I guess you just explained it very clearly, which you did. So I would take that as a good sign. So I'm going to give one more round of applause for Mika. Thank you so much for coming and taking the time to share that.
Thank you so much.
Okay. Well, without further ado, we can go on to our next presenter. So Saqib Islam already has his camera on. Thank you for being so ready and prepared. So he is coming virtually to us from Manitoba, where he's doing his master's in computer science at the University of Manitoba. And he's got extensive experience in lots of areas kind of related to AI and medicine, computer vision, predictive modeling. But the project that he's currently doing is about a validated AI tool that can help automatically detect joints in the hand and wrist and predict their, I believe it's called Sharp van der Heide score from radiographs. So I'm really excited to learn more about this and how it can be used for rheumatoid arthritis. So thank you.
Yeah, thank you, Gemma, for the introduction. Thank you for having me here and thank you for being here. So without further ado, I'll just start my presentation. Is my screen visible to everyone? Okay, that's great.
Yep, and it's in presenter.
Okay, that's good. Okay, I'll start. So the topic I'll be presenting today is deep learning-based joint detection and Sharp van der Heide score prediction in RA, or rheumatoid arthritis hand radiographs. So this is a part of my master's project. A brief outline about the presentation that I'll be presenting today, starting with the introduction, then moving on to the background and motivation behind the project. Then I'll discuss a bit about the datasets that we used in the project and also the methods that we applied and tried. And lastly, ending with the evaluation of the trained models and the results and conclusion. Okay, so a bit of background about rheumatoid arthritis. It is an autoimmune disease that attacks the tissues near joints and other body parts, particularly in the hands and wrists of patients. It causes chronic swelling and pain, and that is sometimes severe, and if left untreated, it can be fatal as well. The problem with RA is that if it is not diagnosed at an early stage, it kind of progresses pretty quickly, and early detection is necessary to provide appropriate treatment plans to treat it and make sure that it does not progress to a very severe state. And it is a difficult task to do it from baseline images and also requires a lot of expert intervention to do so. So a bit of background about this SHARP score, or SHS score as we call it. It's a scoring system that is kind of the gold standard in rheumatology to assess the progression of joint damage in patients with RA. So what a rheumatologist does is analyze the radiographs of hands and feet of patients. And for each of the joints present in the hands and feet, they they assign two scores to each joint based on the erosion of the bone and also the narrowing of the bone. And this is done by analyzing the X-rays of the hands. And it requires a lot of expert intervention, as you can expect from this image. So what was the motivation behind the project? So the motivation behind the project was to perform this evaluation. We basically start with patient radiographs, which can be from multiple follow-ups as well. And then we have this time-consuming and expert-dependent scoring process where we score the individual radiographs, each of the joints of the radiographs. And then we end up with this sharp scored radiographs. And from these radiographs, the expert again has to analyze the scored radiographs, calculate the total score, and then determine the diagnosis and treatment plan for that particular patient. So since this part of the process is time consuming and very expert resource dependent, we decided deep learning might be able to help here. And how it can be helpful is it can do two things separately, not together like expert does, but we can divide the task into two separate tasks. One is the joint detection. So firstly, we want to detect the joints in the hand and classify them into the different joint types that are present in the hand. And the second task would be to predict the damage or the score that was assigned by the rheumatologist to each of the joints that has been detected in the previous stage. And each joint has two associated scores assigned to it, as I mentioned before, the erosion score and the JSN score. However, there's a caveat with the wrist joint. The wrist has several individual joints as well within the whole wrist image. And they have to be assigned separate scores as well. So this is where we thought maybe deep learning could help, and we wanted to try a few approaches to see how it performs compared to the ground truth expert annotated images. And a few other motivations was there is also no large publicly available data set of adult radiographs with RA. So it is difficult to evaluate models on RA-affected radiographs. Also, there are no AI methods currently that show that we could train on normal or healthy radiographs and later evaluate them on radiographs and they would perform well as well. And finally, external validation of predicting SHS score using AI has not been established yet, as of we know in literature. So moving on to the data sets that were used in this project. So we used a total of 4 data sets. The first data set, I'll just briefly describe them and I'll go into details in the later slides. The first data set is the RSNA pediatric bone age challenge data. This was used to fine-tune the joint detection model. This is a publicly available data set. The second one is a Canadian early arthritis cohort data, which is a CATCH data. And it contains expertly annotated SHA scores of patient radiographs. And this data set was used to train the damage prediction part of our model. The third data set is the Manitoba early arthritis cohort data, and we use this data for external validation. We do not train any models on this data, particularly the external validation of the joint detection model. And finally, the COCO data set, which is a very publicly available data set commonly used in object detection and computer vision models. This was just used to pre-train the joint detection model as mentioned in the previous presentation, how pre-training works. And this was used in the joint detection stage. So going to a bit more details about the data set so that we can understand how the models were trained better. So the RSNA pediatric bone age challenge data consisted of children's hand skeleton radiographs, basically. They only contained the left-hand images of the pediatric hands. In total, there were 240 training images and 89 testing images, and each of them contained labeled bounding boxes. And by labeled bounding boxes, I mean the joints in the radiographs were boxed out using these boxes, and these were the labels that the models were trained on to predict the ground truth boxes in each of the radiographs. And it also consisted of the different joint type labels. For example, over here we have the DIP, PIP, MCP, wrist radius, and ulna joints. And these were also classified by these were also predicted by the model, like the particular joint type associated with the bounding box that it was detecting. The second data set is the common objects in context data set, which is a large scale object detection, segmentation, and captioning data set. It also contains labeled coordinates of bounding boxes for 80 categories of objects, which includes person, car, bicycle, dog, cat, etc. We trained the object detection model, or in other words, the YOLO V4 architecture, V5L6 architecture, which was pre-trained on the COCO first, and then we fine-tuned the model on the RSNA pediatric bone age data. The third data set that I'm going to talk about is the Manitoba early arthritis cohort data, which contains serial radiographs from 4 adult RA-affected patients. There were radiographs of 53 pairs of hands, and each of them were manually annotated by a clinician working with us with bounding boxes for the joints. And this was used for external data evaluation only, and no training was done on this data. And finally, the Canadian early arthritis cohort data, which is a large data set containing multiple follow-ups from 530 adult patients. Serial radiographs from 530 adult patients. Each of the radiographs had a labeled erosion and JSN score, or in other words, the sharp scores for each of the joint in the radiographs. In total, there were radiographs of 2,249 pairs of hands, and they contain both healthy and RA-affected hands or patients. However, the dataset was very highly imbalanced. That means that there was very few highly damaged hands who had high scores. The mean erosion and JSN score was around 1 to 1.2 for the whole data set. This was used as an internal data and used for training the damage prediction model. So yeah, that's a mouthful about the data sets used in the project. Now we'll move on to the methods that we tried using the data sets. So what we did was we first started training from a pre-trained YOLO V5L6 model, which is a state-of-the-art in the object detection, currently in literature for object detection and computer vision. This was pre-trained on the COCO dataset first, and the weights were saved. Later, the model was fine-tuned using the pediatric bone challenge data. And then after fine-tuning the model, we use this object detection model with its weights saved to extract or detect joints in the catch data set. And as just to mention that it was trained on pediatric healthy hands, and then the model performed relatively well when it detected ARIA-affected radiographs as well. And the final step was to use this detected joints and do some post-processing on them, to label them, to label the correct positions of the joints and the type, and then crop them out into the different PIP, MCP, radius, wrist, and ulna joints, which we used later for training the damage prediction model, but a bit more about that later. We use several augmentation techniques such as mix-up, mosaic, rotation, translation, and sharing augmentations to ensure that the model generalizes well, since it was trained on healthy joints of pediatric hands, which has a few differences clinically when compared to adult hand radiographs. And it looked like the augmentations did their job relatively well when we compared the results later on. And for the damage prediction model, we chose a multitask approach to do this. Since the goal is to train the model on joint images, and each particular joint has two associated scores assigned to it. One is the erosion score, and one is the joint space narrowing score. We wanted to share the intermediate representation that the model learns, and then output the two scores separately instead of training two separate models for outputting each score. So in this way, we can save both time and also memory by sharing the neural network backbone. We tried a few different vision architectures for the backbone. Some of them were convolutional neural network based, and some of them were transformer based, particularly vision transformer, which is gaining some traction in the object detection and computer vision literature recently. And we used weighted sampling during the training to account for the class imbalance data. Then moving on to the evaluation of how we evaluated our models. Just to give an idea of how the joint detection evaluation works. So we use this metric called intersection over union, which calculates the overlap between a ground truth bounding box and a predicted bounding box by the model. And based on this overlap, if the overlap meets a certain threshold, for example, if we set the threshold to be 0.2 and this overlap is 0.3, then we consider it a true positive classification. However, if the overlap is less than 0.3, and if the threshold is set for 0.5 and the overlap is 0.3, which is less than the threshold, it's not considered a true positive classification for that particular joint. And for the from using this metric, we calculate the average precision, and the joint detection model also does the classification of the joints into the different joint types, which is the MCP, PIP, wrist, radius, and ulna. And to detect the classification performance of the model, we use the commonly used F1 score, which is a harmonic mean of the precision and recall of the model. And for the joint detection bounding box classification problem, we use a mean average precision, which is basically the average precision of all the classes present in the detection problem. And average precision is defined as the area under the precision recall curve for each class. And later on, moving on to how we evaluate the damage prediction model, we use the root mean squared error to calculate the distance between the ground truth scores and the scores assigned by the model. Balanced accuracy, which is an enhanced form of accuracy defined by this formula, sensitivity plus specificity divided by 2. This is better when we have a highly class imbalanced data set when compared to accuracy, because in accuracy it contains the total number of classes present instead of putting any weight on the individual classes which are imbalanced. And also we use an F1 score to evaluate the classification of the joint scores. And here's a bit more about sensitivity and specificity, which is the true positive rate and the true negative rate. So moving on to the results after describing how we evaluate the model. So this is the first result on the RSNA-Bonich test data, the public data on the 89 testing images. And from here, we saw that pre-training the model on COCO, it performs better when it is identifying the joints, both all the joints together and individually, the individual joints separately. The metrics for the individual joints are also presented. When no pre-training was done on the model, it performed well, but not as well as the pre-trained one. So we decided to stick to the pre-trained YOLO model for the next steps of the project. This is the results presented on the external data that we used for the internal data that we used for external validation. So none of the models were trained on this data. And as you can see, the pre-trained and fine-tuned object detection model performs relatively well, not as well as it did on the public data, but it performed relatively well since it was adult radiographs compared to the pediatric hands it was trained on. And most of except for the radius and ulna joints, I guess it struggled a bit with the ulna joints in particular when compared to the PIP MCP wrist radius joints. And then I'll present about the results on the damage prediction, which is the next step of the project. After detecting the joints, we predict the scores of each of the joints. And as I mentioned before, we tried different neural network backbones for training the models. And the best results that we achieved are presented here. As you can see, for detecting the erosion and JSON score, the vision transformer model outperformed the other two CNN-based models in terms of accuracy, F1 score, and RMSE, all of the metrics. So in RMSE, the lower is the better because we want to reduce the distance between the ground truth score and the score that we're predicting. And the balanced accuracy also relatively well, achieving around a 90% accuracy for both the JSON and erosion scores. We also tried a baseline logic regression model using traditional image features extracted from the joint images, which also performed relatively well. But the vision transfer model outperformed all the other models. Yeah, and then we move on to the wrist scores. So as I mentioned before, the wrist images do not have just one score assigned to it. It has multiple scores assigned to it. In particular, it has like 10 scores for each wrist image. And we train a multitask model to detect all of the scores separately when it was trained on only the wrist images. And for this case, we also tried different CNN-based architecture and vision transformer-based architecture. And as you can see, yeah, there is a lot of information here, but necessarily what they are basically the different joints present in the wrist and how well the model predicts the particular score of that joint in compared to other joints. And here we can see that the EfficientNet V2, which is the CNN-based architecture, performs a bit better than both the transformer-based architecture and other CNN-based architecture in both the tasks of when it is predicting the JSON scores of the wrist and also the erosion scores of the wrist for the different joint types present in the wrist. So it's not the same as the as the previous results where we see that the vision transformer performs well. But the vision transformer also performs relatively well when compared to the other CNN architecture. So a lot more, like moving on from the results and tables, I want to show a few examples on the radiographs on how well the model detects the joints. So these are some positive examples on the external data, which is the Manitoba EAC data. And as you can see, the green boxes are the ground truth annotated boxes by the experts, and the red, pink, orange, and this, I guess, is lighter orange colored, other lighter orange color boxes are the ones detected by the model. And in most cases, it does its job properly at both classifying the joint type and detecting the bounding box of the hand in the radiograph, even when the brightness or contrast is not same. And even like the model also detects joints if the radiograph was split into, like in some radiographs have both the hands present in the radiographs, whereas some did not have both the hands and had individual hands, but it did not struggle with that. But however, in some cases where the joints are a bit obscured or the damage was a bit high, it did sometimes miss a few joints. That is why the performance is not 100%. But most of the time, the classification was done properly. However, it did sometimes miss a few joints in some cases, detecting a few joints. So later on, we combined both the damage prediction and joint detection models together. And as you can see in this image, it does both at the same time. It firstly detects the joint boxes, the bounding boxes of each joint. And then later on, it predicts the erosion score and the JSON score, which is defined by the E and J over here for each of the particular joint that it detects. So moving on to the limitations of the project. So the limitations is the first limitation is the individual wrist joints. As I mentioned before, the wrist has a lot of individual smaller joints present in it, and our model cannot particularly detect each joint present in the wrist separately. So what it does, it detects the whole wrist instead. Also, there is a large class imbalance in the data and very few RA progressed joints to evaluate on, which have high RA damage, which associates with a high erosion and high JSON score. And finally, a further evaluation of larger external data is required to kind of like establish clinical utility of the tool. A few takeaways and discussion is that we established that the model trained on pediatric healthy images can also detect RA affected radiographs when it was trained on the left-hand joints of healthy pediatric images only. And it does it relatively well. And also after detecting the model, it can then extract the joints, and these joints can be detected. These detected joints can be used to predict the severity of the joint damage, which in particular is the joint space narrowing and erosion score of RA affected patients. And future work includes, since we have radiographs from multiple time points, since these are like serial radiographs from multiple follow-ups, we plan to incorporate this longitudinal information into the model, maybe use recurrent neural network based or LSTM based models to incorporate the longitudinal information as well and predict the disease progression from baseline images. And this can help to further enhance the treatment plan. We also plan to develop an online tool where the rheumatologists can upload radiographs and it can do the joint detection and scoring for them, which they can edit later on if they feel like they need to. And we can use the continual learning, which is a process to update the model on new data without it forgetting older tasks. And finally, use differential privacy to de-identify new patient data that is being uploaded to the platform. And the platform I was talking about, we have a brief prototype setup that shows how the platform will work, where the clinician can upload an X-ray and press the estimate SVH button, which will predict these bounding boxes and also predict the erosion and JSN scores associated with each joint. And with that, I'd like to end my presentation. I would like to thank my supervisors, Dr. Pinjahu and Dr. Carson Lung, and also the clinicians that worked in our project, the catch investigators who did the hard work of annotating the catch data set that we used, containing the erosion and JSON scores, and the lab members of my lab, Winnipeg Health Sciences Foundation, Manitoba Medical Services Foundation, Canadian Research Chair, and also thanks to University of Toronto for having me here give this presentation. Okay, that's all from my side. If anyone has any questions, feel free to ask them. Thank you.
Saqib, that was awesome. I learned a lot, and I think that your work is contributing to a very important area. There are so many joints in the hand, and having a tool like that could, I think, make a huge difference clinically, and also for the care of patients. So if anyone has any questions, now would be a good time to ask. Laura?
Yeah, that was fantastic. Really impressive project, especially for master's work. That was a phenomenal amount of work and really well presented. I had just a couple of questions. So the first is on the different cohorts. You nicely described all the cohorts in the study, and I was just that you used for your training. I was just wondering, were there any particular selection factors about how people get into these cohorts that may contribute to some bias? Like how did the patients end up in these particular cohorts? Did some have more strict inclusion criteria versus others? Can you say anything about that?
Yeah, thank you for the question. That is a great question. So the thing about the cohorts is, since due to the privacy and privacy of the data, we were not given any information about the demographics or the other clinical aspects. What we worked with was just the radiographs, which did not have any, which like all the patient information will also removed from the radiographs. So I'm not entirely sure about the inclusion criteria. But maybe if that information is available to me, I can get back to you after consulting with the clinicians who collected the data.
Yeah, even if there's some sense of the patient population that they serve at these centers, you know, that might be helpful as well. But yes, I can appreciate the challenges with getting that information. My second just follow-up question, this is just a bit more of a clarification on slide 18, and I apologize if I missed it. Can you tell me again how, oh, not slide 18. It's the threshold slide.
17?
Yes, thank you, 17. Can you tell me again how those thresholds were determined?
Okay, yeah. Yeah, sorry, I was,
yeah,
sorry, I was not particularly clear on this. So we try a few different thresholds because with object detection, we want to make sure that the model performs well in all of the thresholds. If we set the threshold to be 0.1 or 0.5, it should perform relatively well in all of those thresholds. Let me just show an example. So over here, the threshold, if we set it as 0.2, it will be a true positive. If we set it at 0.5, it will be a false positive. So basically, if we increase the threshold, the evaluation metric is more strict on how it is judging how much the boxes overlap. So the results that we present over here, as you can see, the MAP 0.1 is basically with a threshold of 0.1. And in this setting, it performs the best. However, the MAP, as you can see, without any threshold applied to it, is basically the average of all the thresholds. So we calculate the results using 0.1 threshold, 0.2 threshold, 0.3 up to 0.5. And then we average all the results that we obtain from those different thresholds and present them as MAP. this is.
Yeah. Okay, yeah, so it's a bit, yeah, it's more complicated than I thought, but that helps explain, and that makes a lot of sense.
Okay, yeah, I hope that answers the question.
Yeah, it does. Thank you so much.
Okay.
Great presentation.
Thank you.
I also have a question. So I think at the end you mentioned that it misses joints with worse damage, right? More often. So I'm wondering why you think that might be the case. Would it be because like there was less of those in the training data, do you think, or would it perhaps be due to worse damage being more variable or different in adults and children? What are your thoughts on that?
Yeah, thank you for the question. So at least from my experiments, what I saw that since this model was not even trained on the adult radiographs, it was trained on pediatric radiographs. And there's a few differences in the ossification of the joints between the pediatric hands and the adult hands. And also the pediatric hands were healthy and the model did not see any RA affected joints before. So probably that is one of the cases why it misses a few. In future work, maybe we can train the model a bit more on RA affected hands as well, so that it can see a few examples of RA affected hands. But currently our goal was to see if a model that was trained just on like pediatric healthy images can like detect adult radiographs as well, and how well do they do that at generalizing. So maybe like fine-tuning a bit more on the RA affected hands can improve the results in this particular sector.
That makes sense.
Hope that answers the question.
Conrad, our last question.
Perfect. Thank you so much. And thank you for the great presentation and also for highlighting these potential interesting clinical applications as well. My question kind of relates to the previous one. I was wondering if there was some evaluation of the model's performance based on different levels of SVH scores. So for example, maybe some early stage RA versus maybe some more later stage RA, or if that's maybe potentially a future direction as well.
Yes, thank you so much for the question. So for the ablation studies, we did perform a bit, but the problem with doing that is that we do not have the annotated boxes for all of the catch data set. So it's a bit difficult to do since the catch data set has most of the examples of the RA affected radiographs, we first have to manually annotate the boxes in those affected hands and then perform the ablation study. So this might be something we will do in the future when we have time to like annotate the individual boxes in the catch data as well, since the catch data does not come with the bounding boxes. But yeah, that is a great direction that we should explore further to establish the utility of the model.
Thank you.
Okay, thank you.
Okay, depending on how quick this question is, Ashish, maybe you can squeeze it in before we move to our next presenter.
Yeah, hi, great talk. I was just wondering, maybe I missed this, but did you consider how well the model does on data outside the health system? Like radiology AI often is sensitive to the scanner that is used. So I was just wondering, did it, like when it encounters data which is from a different scanner or a different, like either in future work, or like, have you considered that at all?
Yeah, thank you for the question. I believe I can answer the question using this, using the data sets that were used. So from my knowledge, I know that the Manitoba early arthritis cohort and the Canadian early arthritis cohort, they do not have an intersection, and they were probably not taken from the same hospital as well. And the Canadian early arthritis cohort also contains radiographs from different machines or different hospitals combined together. And since the model was externally validated on this data, I believe like maybe if they do not use the same scanner, I do not know the details about the scanners, but if they are different hospitals and probably they might have different scanners, and that the model was like validated using this data as well. So maybe it like generalizes well to different scanners as well, given that these two cohorts had images taken using different scanners.
Thank you. Like, I was just thinking hypothetically, like if I were to try to apply this model to Indian patients, would it work as well? Just thinking aloud. But thank you.
Yeah. Okay. Thank you so much. Yeah, maybe I cannot answer that entirely. We have to test it out to see if it works out.
Well, sounds like you have a next project lined up already. So that's great. Thank you again so much for your presentation. It was wonderful. I guess one last round of applause before we move to our third speaker.
Yeah, thank you for your time. Bye-bye.
All right, so our third speaker, Dr. Mohammad Khan, is a family medicine resident at the University of Toronto. And prior to his career in medicine, he was actually a data scientist working for TD, but I think fell in love with the intersection of AI and medicine and is now luckily here with us. Today, he's presenting to us the REVOLT study, and which that looks at machine learning quantification of fluid volume in the eye with retinal vein occlusion. So I'll maybe leave it to you to explain more to us on why that's relevant and who has retinal vein occlusion. So over to you, Dr. Khan.
All right, thank you so much for the warm introduction. I'll just share my screen here. Okay, can you see my screen now?
No.
Not yet. What about now?
Oh, it looks like it's loading.
Perfect.
Yep, we're good.
All right. So I'd like to first thank the organizing committee for being really accommodating with this talk and for giving me an opportunity to share my previous research during early on in medical school on machine learning quantification of fluid volumes in eyes with retinal vein occlusions undergoing treatment with aflibercept. So retinal vein occlusions are basically the second leading cause of retinal vascular blindness, and their prevalence is expected to increase to around 20% of patients with retinal vascular problems by 2050. And the main course of treatment for retinal vein occlusions are anti-VEGF agents for the macular edema that can tend to grow or form as a result of a vein occlusion. And so just some background information. So recent meta-analyses would find that there would be an increase of more than 15 letters in their best corrected visual acuity, which is just when a patient is looking at, similar to their Snellen charts, just looking at how many letters they can see. And after treatment with 1 year of treatment of intravitreal aflibercept, they would find that kind of increase. And so BCVA, or best corrected visual acuity, is a crucial prognostic consideration in RVO treatment trials. Now, optical coherence tomography, or OCT imaging, has allowed for anatomical assessment and correlation to treatment progression. However, measurements that were used in initial pivotal trials, such as the central subfield thickness, or just like the overall thickness of a specific layer of the retina, was demonstrated to have poor correlation to visual outcomes. And instead, fluid analyses of intraretinal fluid and subretinal fluid were demonstrated to have promise in predicting functional deficits in macular edema due to RVOs with correlative results. But there was a lot more further work to be done that needed to be examined with combined biomarkers and the relationship to visual acuity. So with increasing expectations for accurate prognosis of visual outcomes, more diverse imaging biomarkers would become crucial for the assessment of retinal vein occlusions. And so the exact impact of individual morphologic OCT changes on visual outcomes for RVO patients remains unclear. However, the quantification of intraretinal fluid and other OCT morphological features have shown some clinical relevance. For example, decreases in intraretinal fluid are known to correlate with improvements in visual acuity, and simultaneous quantification of fluid volumes and retinal layer segmentation through a deep learning-based method of OCT scans could provide novel biomarkers to aid in the diagnosis and prognosis of RVOs. And so machine learning has really revolutionized image analysis and provided significant insights into layer and fluid segmentation and evaluation of retinal diseases. However, despite these advances, little has been done to predict the recurrence of RVO-related diseases or therapeutic needs in anti-VEGF therapy, and a lot of the understanding of the pathology for RVO disease. And so machine learning models have not been fully utilized for a deep learning-based approach for fluid segmentation and development of clinically relevant biomarkers for RVOs. So I just want to talk a little bit more about the pathology of RVOs. So within the retina, there's a vascular complex of layers that supply the different tissues or different functions of the retina. And in these, there's two main vascular plexes that we're interested in. The superficial and deep venous complexes are known to be affected. And it's known that the deep venous complex of the retina supplies the internuclear layer and the outer plexiform layers of the retina. And it's also known in previous studies that the DVC is preferentially affected over the superficial venous complex, and the DVC is known to be the principal venous outflow system for the retinal capillary plexes. And so obstruction of the deep venous complex through ischemia or occlusion could lead to macular edema development, with cystoid spaces seen in the internuclear layers, ganglion cell layers, and Henle's fiber layers, just different layers of the retina that are associated with when problems occur there are problems with vision later on. And so the purpose of this study is to evaluate the correlation between visual function and morphological characteristics, such as fluid volumes in eyes with macular edema undergoing treatment secondary to retinal vein occlusions using machine learning. Another goal is to identify potential OCT biomarkers that could aid in the prediction and prognosis of visual function. And this design of the study was a phase 4 retrospective proof of concept study conducted at the Vitreous Retina and Macula Specialists of Toronto. And so our study involved 49 treatment-naive eyes, which were diagnosed with visual impairment due to RVOs that were either diagnosed as a central retinal vein occlusion or a branch retinal vein occlusion. OCT data was used to assess retinal layer thickness, as well as quantify intraretinal and subretinal fluid using an algorithm that would first segment the images by layers and then segment the fluid. Baseline OCT morphological features would be correlated within 6 months with 6-month change in visual acuity using a Pearson correlation coefficient to determine which features were most correlated with change in visual function. Of our study population, 20 patients were for branch retinal vein occlusions and 29 were for central retinal vein occlusions. And the patients were treated with 3 monthly intravitreal injections and then bi-monthly up to a maximum of 1 year. Our inclusion criteria for patients were aged more than 25. They were diagnosed with BRVO or CRVO and treated with aflibercept. And if they were OCT scans performed at each visit. An exclusion criteria would be poor quality images of the OCT images, precluding evaluation by AI software, and absence of diabetes or diabetic retinopathy and any other retinal disease that could confound results. And so just going into the imaging algorithm, so a deep learning based algorithm was implemented to segment fluid regions within each OCT volume. So the method is developed by another corporation, Boxelron, and what the method basically does is takes each OCT scan as an input, and a segmentation mask is generated automatically using Orion software, which is another software developed in San Francisco. And the deep learning architecture used for first the training and subsequently the testing was that of UNet, which is a version of the autoencoder that uses skip connections to better maintain detail across different scales. UNet uses 3 encoding and decoding levels, and learning was based on minimizing the model's loss, where the loss function combines categorical cross entropy, and a weighted dice similarity coefficient. This was a model that was previously used in our previous studies in age-related macular degeneration and showed good response there, being clinically consistent with ophthalmologists who would evaluate fluid segmentations themselves, and the model was significant there. So we decided to use this for RVOs now. And so the subsequent fluid analysis would then examine the linear trends between the baseline fluid levels in different regions of the macula with the 6-month change in visual acuity. And this relationship would be measured through the Pearson correlation and confirmed if the PC correlation remains strong when comparing 6-month change in fluid with 6 months changed levels in BCVA. Another aspect that we do was to use an Python algorithm to just analyze OCT-A or OCT angiography images of the deep venous complex consisting of 6 by 6 millimeter square snapshots as a proof of concept experiment. OCTA scans with poor image quality were filtered out, and images were analyzed in Python to just estimate areas of non-perfusion that were described in previous studies, which is just a measurement of the darker pixels to the light pixels based off of a threshold value. These estimated areas of non-perfusion were converted into indices of ischemia based on a formula of just area of non-perfusion over area of visible retina. And so then we get into the actual results, starting off with thickness and fluid measurements from our algorithm. So we note that for individual features for patients with BRVOs, that layer thickness was highly correlated with visual function, especially for the outer plexiform layer, while fluid was more weakly correlated and subretinal fluid was not being significant. This was also the same case for our CRVOs, or central retinal vein occlusions. So while the individual correlations weren't that strong, what we wanted to look into next was if we could combine fluid volume with layer thickness, would that improve correlations? And what we found that it would indeed improve, outperform individual metrics significantly. A combined model of intraretinal fluid, the outer plexiform layer, and the retinal nerve fiber layer thickness provided the best correlation to changes in best corrected visual acuity for patients with CRVOs at a significance 0.865, while BRVOs, it would be similar with significant correlation at 0.805. And the ischemic index from our analyses was also highly correlated with change in BCVA for patients at significance 0.91 and 0.92. However, we do recognize the limited sample size for our ischemic index analyses. And so just going over some of the limitations of our study, we recognize that the sample size is around 49 eyes. There was a misbalance between BRVO and CRVO eyes, where there's 20 CRVO and 29 CRVO. OCTA also does lack sensitivity to detect low flow, which may affect these ischemic indices. And there are layer segmentation issues that are known when eyes have macular edema or fluid in that eye that can cause some further issues. And this is a short-term follow-up study of only 6 months. So clinically though, what did our results really indicate? It basically shows that some of our results are clinically consistent. A combined model of IRF, OPL thickness, and ischemic indices of the deep venous complex provided the best correlation to visual acuity changes. Clinically, what this is telling us is that increased fluid with disruption of layers leads to poor visual function, which is something we further understand now about the deep VC. So we know that the deep venous complex, it supplies the outer plexiform layers, and RVOs preferentially impact the deep venous complex. So as macular fluid would build up, these vessels in the DVC would have reduced flexibility to accommodate the fluid and become more occluded, causing further damage to these retinal layers. And flow derangement within the deep venous plexus is a critical aspect to vision loss in eyes with macular edema secondary to RVOs. And so, in summary, to conclude this talk, we know that supervising deep learning models can be successfully applied to retinal vein occlusions for OCT analysis. the impact of RVOs to the deep venous complex and its impacts on retinal layers can be measured, particularly in the outer plexiform layer. And multiple layer and fluid biomarkers may provide a better correlation to visual outcome in retinal vascular disease than just a single fluid or layer biomarker alone. And ischemic indices could offer another biomarker to combine with fluid and layer segmentation analysis that could be highly correlated with visual acuity outcomes in CRVOs and BRVOs. And lastly, larger studies examining biomarkers in RVOs will further enhance our ability to forecast visual outcomes. And so I just want to give some acknowledgements to Dr. Nain Chowdhury, who is my supervisor for this project, along with the rest of the team for VRM Toronto, and also to Jonathan Oakley and Daniel Riskov, who are the AI engineers responsible for the algorithm that we use from Voxeleron. Thank you very much.
Awesome presentation. Thank you so much for that. So we do have 10 minutes for questions if anyone has a question they would like to ask.
Oh, I see a question in like the chat. I did say anti-VEGF.
Yeah.
So VEGF is kind of interesting how the mechanism of visual acuity loss in RVOs is actually very similar to what's going on in cancer, in the sense that because these vessels become occluded and ischemic, this ischemia gives the eye vessels, or like the vessels around there, a response to create more vessels. And these vessels are very leaky and cause edema because these are leaky, poor performing vessels. And so in studies of just using anti-VEGF to basically kill off these vessels, then patients would have like better visual acuity outcomes as a result.
That's really interesting. I have a question for you. So the work that you did, I think it really deepened and enhanced the understanding kind of behind the disease mechanism, and kind of further explaining and providing like robust evidence as to why patients experience those symptoms. Do you see any utility for this kind of in a clinical setting, or is this work kind of more something that like are there next steps, I guess is my question.
So further next steps would be, so now that we see that fluid and ischemia is correlated with long-term outcomes of visual acuity, these measurements were done at baseline to see if they would be predictable of their final outcomes. And so we're seeing fluid volumes and ischemia, patients who have high fluid volumes and patients who are highly ischemic have better outcomes after being dealt with anti-VEGF agents. And so there's still more work to be done with larger sample sizes to see the predictability of using these biomarkers to see how well a patient is going to respond to treatment of anti-VEGF agents.
That makes sense. And is there a way to measure the biomarkers in a cost-effective setting in the clinic? I wasn't sure about like how the patient sample, I guess, is collected.
That's something that could definitely be further explored about the cost effectiveness of these agents as well.
So I had a question. I was wondering, was there any longitudinal data, like as is it like a you detect RDO and then immediately treat them with anti-VEGF and then the acuity becomes better? Or is it like you track them over time and do multiple OCT scans? And if it's longitudinal, can you use the initial scan to predict disease progression and decide what kind of therapy would benefit them?
Yep. So this was a longitudinal study in a sense, because we were using baseline OCT scans who were then treated with aflibercept, and then they had monthly visits, and we looked at their 6-month follow-up outcomes for visual acuity to use as like prediction. And so while we were doing the study, we were also examining another aspect to the study, is just seeing not just if baseline would correlate with final visual outcomes, but also if the final fluid volumes also correlated with final outcomes to see if the trend was confirmed. And we would see that as well. So there was a bit of like using all the data from our longitudinal site to determine our results.
And like a quick follow-up, I was just wondering, are there multiple VEGF inhibitors that you use? And like, can this biomarker be used to possibly help in clinical decision support of which one to use for which patient?
Yeah, so there's multiple anti-VEGF agents that are used, including ranibizumab as well. And so definitely a further study that could be quite interesting is seeing how different anti-VEGF agents respond to fluid outcomes based off of these biomarkers, and could definitely be used to potentially help clinicians decide which agent might be best in the future.
Awesome. Well, thank you so much for the questions and your responses as well. And thank you again to all of the 3 speakers who each shared, I think, very different but very interesting projects. It's cool to see how AI can really interface with medicine. And I think you've all inspired me. I feel like I must go back to work and work on my own research now, because those were really exceptional projects. And I'm sure the students on the call also feel the same, as many of them here are doing their summer interns with T-CAIREM. So with that, we will close the session. Thank you to everyone for coming, and thank you again to the 3 speakers for your presentations.